Hello everyone. In this video, I will talk about all of the important points that you need to know about Graves' disease. And stay tuned till the end because I will also discuss the important eye signs which are involved in Graves' disease. Now, Graves' disease is an autoimmune condition and it is a cause of primary hyperthyroidism, which means that the increased thyroid hormone levels which happen due to Graves' disease are due to a problem in the thyroid gland itself, and the hyperthyroidism does not arise from any other organ. It's from the thyroid gland itself. Graves' disease is the most common autoimmune cause of hyperthyroidism. Now, Graves' disease is clinically a triad of three main clinical features: hyperthyroidism or thyrotoxicosis, ophthalmopathy, and pretibial myxedema. This is the triad. The risk factors will include smoking, somebody who's taking antiretroviral therapy for HIV. Then, if we talk about the gender, the female gender is more commonly affected than males, so females are a higher risk factor. In the age group of 20 to 50 years is most commonly involved. Then, if we talk about genetic susceptibility, the people having CTLA4, PTPN22, these genes are more affected. And in infections, E. coli and Yersinia infections are known to predispose the Graves' disease. Since Graves' disease is an autoimmune condition, there will be antibodies present, and the most common antibody associated with Graves' disease is the anti TSH receptor antibody, which is a stimulating kind of antibody. So, usually, what happens is that if antibodies are produced against a receptor, then they will reduce the function or they will destroy the receptor. But specifically in Graves' disease, these anti TSH receptor antibodies lead to the stimulation of this receptor, causing symptoms of hyperthyroidism. Other than that, we can also have anti TPO or anti thyroid peroxidase antibodies and anti thyroglobulin antibodies. Now, let's talk about the pathogenesis of this condition. So, in the thyroid gland, every single thyroid cell will have a TSH receptor on it. Now, TSH hormone or thyroid stimulating hormone will bind to this TSH receptor and it will stimulate the production of thyroid hormones. This is what happens normally, that under the stimulation of TSH, thyroid hormones are produced by each of the thyroid cells. In Graves' disease, we have IgG antibodies against the TSH receptor on the cells of the thyroid gland. These antibodies will bind to the TSH receptor, and instead of destroying them, which is what happens in usual autoimmune diseases, they will instead stimulate them even more, causing the thyroid cell to produce even more thyroid hormones and leading to symptoms of hypothyroidism or thyrotoxicosis. So that is what happens here. The TSH receptor antibodies will lead to an increased synthesis of thyroid hormones. Now, hyperthyroidism is not the only symptom that they cause, because these TSH receptor antibodies can also activate fibroblasts and T cells. These activated fibroblasts and T cells lead to an increase in the production of glycosaminoglycans, which are substances which trap water. And if water gets trapped in the soft tissues, it will lead to swelling of the muscles as well as the soft tissues. This causes the second set of symptoms in Graves' disease. And these symptoms are specific to Graves' disease. They will not be seen in any other condition which involves hyperthyroidism. Now, the first set of clinical features are due to increased T3 and T4, that is due to hyperthyroidism. So, we will have metabolic clinical features like weight loss despite an increased appetite. The patient will have a heat intolerance. Then, autonomic clinical features like sweating and tremors. In the CVS, the patient will have palpitations. If we say neurologically, the patient will experience increased fatigue, irritability, and the patient will be emotionally labile, and the patient will also experience a lot of anxiety. Then we have gastrointestinal symptoms like diarrhea. In the eye, the patient will experience diplopia. There will be a weakness in the muscles, And in the genitourinary system, we can have infertility in both males and females, and specifically in females, there will be amenorrhea or oligomenorrhea. So there will be reduced amount of menstrual bleeding seen in hyperthyroidism. The second set of clinical features arise due to soft tissue swellings that will involve ophthalmopathy, leading to proptosis or protrusion of the eyeball beyond the orbit. There is lid retraction, excessive lacrimation, diplopia, reduced visual acuity, and reduced color vision. There is also pretibial mixed edema, which is an infiltrative dermopathy. Again, this is seen due to increased water accumulation in the soft tissues, and it will present as raised pink purple plaques on the anterior aspect of the leg. If we look at the signs that we observe as clinicians, there might be goiter, and then the patient will experience weight loss. There will be tremors, sinus tachycardia or atrial fibrillation might be seen in the ECG. If we look at the eyelid, there might be a retraction or a lag. There is also heart failure, proximal myopathy, and the deep tendon reflexes will be exaggerated. Now, there's a lot of eye signs that arise in Graves' disease, and here I have listed out a few very important ones that you need to know. So, the first one is Dalrymple sign. This is the most common sign that we see, and this is retraction of upper eyelids. So, the upper eyelids will be retracted, they will be pulled back a little bit. Then, the next one is Von Graves sign. In this, when the patient is asked to look down or when the globe of the eye moves down, the upper eyelid will lag a little bit, which means that the lid will not move instantly. As soon as the eye is moved down, there will be a bit of a lag. The next sign is Enroth sign, where we see edema in the eyelids. There will be edematous eyelids. In Stelvag sign, we will see that the patient blinks infrequently. In Geoffroy's sign, when the patient is asked to look up, usually what happens is our forehead wrinkles up. But in thyroid eye disease, and specifically in Geoffroy's sign, the forehead wrinkling will be absent or it will be poor. Next is Hertog sign, which is a loss of the lateral one-third of eyebrows. So if you look at the eyebrows, lateral one-third part will be lost. Finally, Mobius sign is an inability to converge the pupils. In the investigations, the first one that we do is serum T3 and T4 levels, which are going to be raised, and then TSH will be reduced. If we take a biopsy, grossly we will see that the gland is diffusely enlarged, and on microscopy, what we see is scalloped appearance of the colloid. So normally we know that the thyroid cell is lined by tall columnar cells, and in between that is the colloid, which consists of the thyroid hormones. But in Graves' disease, we will see that the colloid is slightly scalloped, which means that it seems like the colloid has been scooped by somebody. And so we will have these whitish appearing areas, and this is called scalloped appearance of the colloid. If we do a radioiodine uptake scan, it will show diffusely increased uptake, which means that the entire gland is taking too much iodine, which is leading to a diffusely increased uptake from the thyroid gland. Then when we test for anti-TSH receptor antibodies, they will be positive in almost 80 to 95% of people. In the treatment, we can give anti-thyroid drugs, which act by inhibiting release of thyroid hormones from the gland. Drug of choice are carbimazole and methimazole, but these drugs are contraindicated in the first trimester of pregnancy because they can cause aplasia cutis in the newborn. Propyl thiouracil is the drug of choice in the first trimester, but it is hepatotoxic, so it has to be later switched into carbimazole or methimazole. These drugs will bring about a euthyroid state by 6 to 8 weeks. The side effects will include hepatotoxicity due to propyl thiouracil, and then all of these antithyroid drugs can cause agranulocytosis and rash. We can also give radioactive iodine here, which is given orally. So it acts by inhibiting survival and replication of the follicular cells because it is radioactive. It will destroy the follicular cells, it will inhibit their survival and the replication, which will lead to decreased production of thyroid hormones. But the disadvantage is that the patient eventually develops hypothyroidism because it excessively destroys all of the follicular cells. Radioactive iodine is not to be given in patients with ophthalmopathy, and it is also contraindicated in pregnant women. Surgery or thyroidectomy becomes the mainstay of treatment in pregnant women and in patients with ophthalmopathy. It is important to give antithyroid drugs and propranolol to the patient before surgery, or it may result in a thyroid storm. I will make a separate video on thyroid storm, so you please stay tuned and like and subscribe for more videos. Thanks for watching.